Hi, my name is Kristen Klim, and I'm recording the Case Connections for Unit 2. Starting with case number 3. A 5-year-old boy is brought into the pediatrician's office for an annual visit. The mother reports he's been a sickly infant and often appears drowsy. She also has concerns over her son's persistent thirst and frequent urination. Blood samples are taken for insulin measurements at the time 0 and 1 hour after a glucose loading test. The results of the test are shown in a chart that we were given, and they show that the patient's serum insulin level at baseline is 0.8 microunits per liter, when the control or normal serum insulin level at baseline should be around 6 plus or minus 2. The results for after the glucose load were also given. The patient's serum insulin level after the glucose load was 5 microunits per liter, when the control or normal serum insulin level after the glucose load should be about 40 plus or minus 11 microunits per liter. The question asks, what is this information likely to suggest about the underlying biochemical basis for the patient's symptoms? So the lab report shows that the patient's baseline blood sample is a lot lower than what it should be. Even after the 1 hour glucose load was given, the patient's serum level still appears to be extremely low. With this patient's symptoms, I created a differential diagnosis list. The patient's symptoms are he's easily fatigued, he's experiencing polydipsia, persistent thirst, and experiencing polyuria, which is increased urination. So the differential diagnosis list consists of diabetes mellitus, hypercalcemia, and hypokalemia. But with the given lab values, we can eliminate a few, and the patient seems to have insulin-dependent diabetes mellitus, which is also known as type 1 diabetes, which is also known as juvenile diabetes. This is when the pancreas is not producing enough insulin, and insulin is what helps them move sugar out of the blood. So with this, we'd want to get a fasting blood glucose, and in order for this to be accurate, the patient would be having to fast for 8 hours. And if concurrent with what we believe that this is, the patient's glucose level would be greater than the normal range. And the normal range of a patient who's fasting is around 100, so we'd expect it to be greater than that. We'd also want to check an A1C test, which is checking the average amount of sugar in the blood after a 2 to 3 month period. And another thing we'd want to receive is a family history. This could tell us a lot about the history of diabetes to see if anyone in the family has ever had it or any issues with glucose in general. That would give us a lot more information as well. And also we were to list 2 regulatory enzymes that are likely to be active in this patient's hyperglycemic condition. And so we assume those are gluconeogenic enzymes. For example, fructose 1,6-biphosphatase that will help turn fructose 1,6-phosphate to fructose 6-phosphate, as well as seeing the enzyme glucose 6-phosphatase that will help turn glucose 6-phosphate into glucose. Those are 2 enzymes, as well as many others that we'd expect to see in this patient's condition. The next case that I decided to focus on is case number 4. A previously healthy 2-month-old female presents with jittery spells several hours after breastfeeding. Her mother reports she's not given the baby anything to eat other than breast milk since birth. The baby has only recently been sleeping for more than 2 hours between feedings, and that's when the mother reports these symptoms started. Laboratory results are consistent with hypoglycemia, which is low blood glucose, but are otherwise unremarkable. Epinephrine is administered, and there is no increase in blood glucose, but there's an increase in blood lactate. Physical exam reveals a liver edge 4 centimeters below the right costal margin. Percussion of the right chest and abdomen reveals hepatomegaly, which is an enlarged liver. The blood glucose levels increase after breastfeeding, but she cannot maintain blood glucose levels within a normal range during fasting. So based on the information, what is the following most likely diagnosis of this patient? We were given 4 options, A through D, and let's start with option A, hereditary fructose intolerance. Consistent with this disease, convulsions are seen and irritability. With this patient, the mother could mistaken the jittery spells to be convulsions, so that could be consistent. And irritability, the patient could definitely be irritable with the given symptoms. But a couple of symptoms that aren't seen in this patient that are consistent with hereditary fructose intolerance are jaundice, nausea, vomiting, gas, abdominal pain, and chronic fatigue. So we can go ahead and eliminate this option. Option B, galactosemia. Again, the mother could be mistaken the jittery spells to be convulsions, which are consistent with this galactosemia, and also lethargy that the patient has. But a couple symptoms that are consistent with galactosemia that the patient does not have are loss of appetite and vomiting. So we can go ahead and eliminate that option. Jumping down to option D, glucose 6-phosphate dehydrogenase deficiency. The patient is experiencing fatigue, which is a common symptom in this deficiency. But the patient is lacking a pale appearance, headache, a sudden rise in temperature, rapid heartbeat, shortness of breath, and dark urine or jaundice. So we can go ahead and eliminate this option as well. Going back to option C, glycogen storage disease, which is the inability to use glycogen. The patient's symptoms are aligned with this disease, as well as the clinical features such as hepatomegaly, the low blood sugar level, and the high level of lactate are all seen with glycogen storage disease, as well as what we have seen with this patient. The reason that there's a high level of lactate is the body is having the inability to convert glucose 6-phosphate to glucose, which is resulting in an abnormal pathway through glycolysis, which is leading to the increased production of pyruvate, which is then converted to lactate. And so that's why we have that. And with that, we suggest this patient does have glycogen storage disease.